So circulatory shock refers to a condition when someone is experiencing systemic hypoperfusion of their tissues. And it can be caused by any number of conditions, and ultimately the consequences of shock are impaired tissue perfusion and cellular hypoxia. Now there are sort of three broad categories of the different types of shock that you can kind of use as a framework for understanding these different types of shock. So the first broad category is hypovolemic shock. Now, hypovolemic just literally means decreased volume, and we're talking about the decreased volume of blood that is within the circulatory system. Some examples of hypovolemic shock would be shock due to hemorrhage. So if someone is bleeding out, you can sort of easily comprehend how they would have decreased blood volume and therefore decreased oxygen carrying capacity in their circulatory system. And another example of hypovolemic shock would be shock from extensive burns. So say someone has burns over an extensive part of their surface area of their body. There's going to be increased fluid loss through these burns, and eventually these people could become hypovolemic and enter a state of circulatory shock. The next broad category of circulatory shock would be shock due to some sort of cardiogenic cause. And cardiogenic just sort of referring to either intrinsic damage to the heart, some sort of extrinsic pressure, or possibly outflow obstruction of the blood that the heart is pumping to the rest of the body. Some common examples would be post-MI or post-myocardial infarction, when someone has a heart attack, dysrhythmia. So say someone's heart gets sort of thrown out of rhythm, then sometimes the heart muscle isn't contracting in a synchronized fashion to efficiently pump the blood out of the heart, and someone can go into cardiogenic shock that way. Another example would be cardiogenic shock from cardiac tamponade. Cardiac tamponade is basically when the pericardial sac that's surrounding the heart becomes full of usually blood that fills to the point that it is putting pressure on the heart muscle itself, and the heart can then have trouble pumping blood. And then there's also pulmonary embolism, or PE, which is an example of outflow obstruction. So if you have a big clot in the pulmonary vasculature, well, the right side of the heart is going to have trouble pumping blood past that clot. And then just the third type of shock is distributive shock, which is a state of systemic vasodilation and pooling of blood. And an example of distributive shock would be septic shock due to some sort of bacterial or fungal infection. You can have neurogenic shock, which can happen as a side effect of anesthesia or in someone who experiences a spinal cord injury. And then you can also have distributive shock due to anaphylaxis. So here we have our three main types of shock, and now we want to look at specific parameters or measurements that differentiate these three types of shock from one another. So to do that, let's draw out a table, and we'll start out by putting the type of shock that we're going to be talking about. And then the four parameters that we have to compare these different types of shock are cardiac output, central venous pressure, or pulmonary capillary wedge pressure, systemic vascular resistance, and venous oxygen saturation, which we'll abbreviate as SVO2. So cardiac output is kind of the measure of the contractility of the heart. Basically, it's a measure of the volume of blood that's pumped by the heart in a unit of time. So central venous pressure and pulmonary capillary wedge pressure are a little bit harder to comprehend, but I'll try to explain it as best I can. These are both basically measurements that reflect the amount of blood returning to the heart in the right atrium. So the central venous pressure is the pressure measured in the central vein, or the vena cava. So this is the major vein that is returning blood back to the heart. And the pulmonary capillary wedge pressure is basically a measurement of the pressure in the pulmonary capillaries, which correlates with the pressure and therefore amount of blood in the right atrium. Now, the systemic vascular resistance is the resistance that must be overcome to push blood through the circulatory system. And this is related to the diameter of the actual blood vessels. So arteries in particular are able to dilate or contract down to control the pressure of blood flowing throughout the system. And so the systemic vascular resistance is a reflection of how clamped down the arteries are. And then systemic venous oxygen saturation is basically a measure of how much oxygen is being consumed by the tissues. So how much oxygen is left over once blood is pumped through the arteries, past the capillaries, and coming out through the venous end of the circulatory system. So hopefully that brief overview of these four terms helps you out a little bit, and you'll see these four terms come up over again in the cardiovascular system. So starting with cardiac output. In hypovolemic shock, cardiac output will be decreased. Because remember that cardiac output is the volume of blood being pumped out by the heart in 1 minute. So if you have overall decreased volume of blood, then you're going to have a decreased amount that is pumped out by the heart. Now in cardiogenic shock, cardiac output is again decreased because this time you aren't necessarily having a decreased volume of blood that's pumped out. That part's constant, but the rate at which the blood is being pumped out of the heart in a minute is decreased, either because of some sort of intrinsic problem with damaged heart muscle, or maybe the rate at which it's contracting or the rhythm is no longer synchronized, or say with cardiac tamponade, there's actual extrinsic pressure on the heart preventing it from squeezing effectively. And then remember with pulmonary embolism, there's outflow obstructions. And then in distributive shock, cardiac output is actually increased. And that's because the amount of blood is constant, but the rate at which the heart is pumping increases. Now the CVP in hypovolemic shock is going to be decreased because again, you have decreased volume of blood, and so the pressure exerted on the vena cava is going to be decreased. In cardiogenic shock, the CVP is actually increased. And that's because blood is not being effectively pumped by the heart, and it starts to back up, if you will, into the system, which means there's actually increased blood volume in the vena cava, and so the CVP will be increased. So remember in distributive shock that there is systemic vasodilation pooling of blood. So if you have systemic vasodilation, then your central venous pressure is going to go down, meaning your vasculature is dilated, which means the pressure exerted on that vasculature is decreased. Now on to systemic vascular resistance, or SVR. Now in hypovolemic shock, there is decreased blood volume. And in response to this, the vasculature tends to clamp down to narrow the diameter of the vessels to try to keep a consistent pressure throughout those vessels, and therefore keeping the tissues as perfused as possible. So the SVR in hypovolemic shock is going to be increased due to the clamping down of all the vessels to keep tissues perfused. Now in cardiogenic shock, when the heart isn't effectively pumping blood forward throughout the system, again, pressure is going to fall, and then the vessels will clamp down in response to try to keep that pressure increased. So the systemic vascular resistance will be increased. And then in distributive shock, remember there's systemic vasodilation, so dilation of all the vessels, and so the systemic vascular resistance will be decreased. And finally, on to the systemic venous oxygen saturation. In hypovolemic shock, the SVO2 will be decreased, meaning the leftover oxygen in the blood that's returning to the heart is going to be lower than normal. And that's because whatever little blood that is being pumped to the tissues, the cells are going to extract as much oxygen from that blood as possible. The same thing happens in cardiogenic shock. Since there is a decreased rate of new blood with fresh oxygen being pumped past the tissues are going to try to extract what little oxygen they can get. And then in distributive shock, there is actually an increase in the venous oxygen saturation. And that is due to a problem with the tissues of actually being able to extract the oxygen from the blood itself. And so if tissues are having a problem with extracting the oxygen, then there will be increased or leftover oxygen in the venous blood.